treatment of lupus nephritis, and he will give the first talk on personalized immunomonitoring and treatment in lupus nephritis. Hans-Jochen.
Yes, Jack, thank you. Ladies and gentlemen, in the field of lupus nephritis, there had been a lot of enthusiasm at the time where new drugs came up in the field of rheumatology, and you're all aware that diseases like rheumatoid arthritis and others have greatly benefited from the new age of biological treatments that can more specifically target immune abnormalities and almost cure autoimmune diseases. And so there were great hopes also in the field of lupus nephritis. But as you can see, the results 10 years later, after having performed a couple of clinical trials, is quite disappointing. And so some people, including our previous speaker, start to raise the question, should we still believe in randomized controlled trials? Because I think here there's a concern that we may discard a number of drugs from our patient only because there had been a negative trial, although they may be quite helpful for individual patients. And I think many of you will have, like myself, a good experience, for example, with the use of B-cell targeting therapies in lupus nephritis, even though a randomized controlled trial turned out negative and is no longer followed by the companies to get approval. So the general concept of personalized medicine is based on the idea that populations are heterogeneous, that toxicities and drug efficacy may not be equally distributed in a cohort of patients, and that's why it will be hard to really meet primary endpoints. And we have a lot of examples in nephrology, like in diabetic nephropathy or also in lupus nephritis. And I will touch on a couple of things that may help here, like genetics or immunophenotyping. But to start out with, I want to make the point that we have another big problem because we assume that the primary endpoint of our lupus trials will be appropriate to really determine drug efficacy. So the remission criteria in lupus nephritis, as they are used in clinical trials, are threefold. One is the serum creatinine, which is funny because in most patients with incident lupus nephritis, serum creatinine is normal, so it's quite useless to use it as a primary endpoint criteria. The second is the active urinary sediment, which has now recently been well documented, is absolutely useless to define remission in patients with lupus nephritis, and also my own experience is that way, that most patients with the lupus nephritis remain with some microhematuria for many, many years. So it's all about proteinuria in the end. And as nephrologists, we are used to consider proteinuria as an important prognostic parameter. But here in lupus nephritis, we use it to answer the question, does it also mimic disease activity? And this may not be appropriate, actually. So I'd like to show you here on the left part of the figure a graph that I took from a review on membranous nephropathy, where now we are able to really see immunological disease activity by the presence or absence of the antiphospholipid A receptor antibodies. And it's quite obvious that proteinuria always lags behind. But the patient needs immunosuppressive treatment only up to when those antibodies are available, and later for the repair of the filtration barrier, immunosuppression may not at all needed. And this is shown on the right part of the figure. This is a patient study published by colleagues. This is a patient with membranous lupus nephritis. As you can see here, it has a fantastic immune complexes present at the first kidney biopsy. But then, obviously, the patient was treated with rituximab and remained proteinuric, so he received a second biopsy. And if you look at his podocytes, you perfectly understand why he's still proteinuric, so still has considerable damage to the filtration barrier. But you can see that all the immune complexes have disappeared, so the treatment with rituximab was exceptionally successful in controlling the autoimmune disease. But if you look only at proteinuria, you completely miss that immunological remission of the disease. And this patient doesn't need at all immunosuppressive treatment anymore, but maybe needs an ACE inhibitor or something to help the repair the filtration barrier. But according to the guidelines and according to the way how we do clinical trials, this is a patient that is not undergoing remission and would recommend to change immunosuppressive therapy to expand it and escalate it, and this is obviously not good for the patient. So as you can see here, kidney biopsy, repeat kidney biopsy is the gold standard to identify immunological remission, because we cannot trust our serum biomarkers on this part in lupus. So there's a whole world of biomarker studies in lupus nephritis, and this is just one example of them, which I like a lot. It looks at the urinary T cells identified by flow cytometry, which you can imagine is not available everywhere where patient care is provided for patients with lupus nephritis. But it anyway shows very well that there is a close correlation between disease activity. But how was disease activity defined? It was defined in this study by the usual parameters, by proteinuria, by the SLEDAI or other activity indices, and that means if you come up with a new biomarker, you can never get better than the ones that you compare it with, and this, like almost all other biomarker studies in lupus nephritis, do not use kidney biopsy as a gold standard referral point, and in this manner, by design, these studies are completely unable to improve of what we're doing currently now. So that's a problem. So I'd like to advocate repeat kidney biopsy here to do in clinical practice to individualize the treatment of your patients. And a few people in the world are doing this, and one of the studies that was showing rebiopsy results is this one with a group headed by Brad Rovin from Ohio, but together with colleagues from Argentina that obviously do protocol biopsies in their lupus nephritis patients. And as you can see here, this is at least 6 months later, but many patients had also 8 or 12 months later the rebiopsy. You can see here that proteinuria came down, but were not normalized. So you could imagine that some of these patients had immunological remission and others simply had still problems to repair the filtration barrier. The creatinine was not so much changed, but there was a trend, well, significant obviously, but as I said, the first biopsy, usually it's in the normal range. The activity index in that biopsy came down, but not down to 0, and that would be required to call it an immunological remission. And the chronicity index, which means scarring, increased. So that means while we're treating the patients with a drastic immunosuppressive treatment, anyway, scarring and persistent damage goes on, which is bad news, basically. So these are complicated tables and graphs I'd like to explain you. These are patients that had all a complete clinical remission. That means they had a normal proteinuria after 6 months or at the time of the rebiopsy. But then in the rebiopsy that was done for protocol reasons, you could find people that had terrible disease activity, although having no proteinuria anymore. So that means if you would go by proteinuria, you would completely ignore that these people have an ongoing disease that should be treated with immunosuppressive drugs. On the other side, if you take all the patients that had a normal activity index in the second biopsy, many of them still had proteinuria of more than 500 milligrams. That means those people would have received continuous immunosuppressive treatment, although not needing it at all. So from this study, we can basically exclude that our current remission criteria that are used in clinical trials are completely useless to tell us whether the treatment was successful, yes or no. And based on this thing, it's a big problem that we have already discarded so many drugs that may have the potential to cure many of our patients, but they failed in a randomized controlled trial setting, and this is a problem. So many people have looked in repeat biopsies that were done on the occasion of flares, maybe in the shift of the classes of the lupus nephritis. So here's the reference biopsy, the first one, and you see the usual classes. And here you see how that may change in the repeat biopsy. And from that, there's the conclusion that for this, I mean, if you have a flare, a proteinuric flare of the disease, it doesn't make sense to do a rebiopsy if the patient had a class 3, 4, or 5 before, because in these patients, a 3, 4 or mixed class, because in these patients it doesn't change and won't have any impact on the way how to treat the patients. While if the patient had a class 1 or 2 or 5 in the first biopsy, then there's a considerable chance that this may change and it will have an effect also on the therapy. Okay, so now I made the point that rebiopsy is important and maybe we should generally do a second biopsy and tell the patient, you got a first one and listen, I suggest that we do a second one in 1 year from now or 8 months from now, just to see if the treatment was sufficient. And I think in young people that is fair, because if you have a 25-year-old female, you want to make sure that up to the age of 90 she doesn't end up on dialysis, and for this reason we need definitely to know whether she was cured or not with the treatment that we give her, okay? But this is a case that will argue against this concept to some extent, because this was a patient that received 5 kidney biopsies with a lupus nephritis, and I show only 3 of them, and you see very well that this was the second biopsy. The first one showed a class 2, and this was done as a protocol biopsy in a kit to see if the treatment was good enough, and the only thing that was seen was one FSGS lesion, which was considered to be a secondary FSGS after episode of lupus nephritis. And then over the years you can see a progression of glomerular scarring, and this biopsy was done by us when she was grown adult, and it was shortly before she ended up on dialysis, unfortunately, and here she had a class 6. So I show you the clinical course. This was at the age of 14, nephrotic syndrome. Here you see the steroid dose, and proteinuria came down with this kind of treatment. Mycophenolate and methylprednisolone, ACE inhibitor, had a complete remission for a couple of years, then had a flare, and had again a biopsy, class 5, received cyclosporin and hydrochloroquine, and had only a partial remission. And at that time, there was no biopsy done, obviously, but a little bit later when proteinuria started to rise again, and here had a class 3-5, and was now treated with an extended regimen of immunosuppressive therapies, and that was the time when she turned 18 and came to my clinic, and at the time already creatinine had started rising. I was not so much worried about the disease, I was more worried about her immunosuppressive therapy, and started to reduce it, and proteinuria came down anyway, but then as you can see she had another flare, and we did the last biopsy, was a class 6, and then she ended on dialysis, unfortunately. So I'd never seen a case like this before, and I wondered what could be the case here. Obviously, repeat kidney biopsy was not very useful to cure the patient. So what we have to consider if we use the term refractory lupus nephritis? Could be highly active. This is what usually is anticipated, and you may prove that by a rebiopsy or simply intensify the therapy also without a rebiopsy, but there could be simply also a drug adherence problem, and that's what the experienced lupus doctors suggest in the first place, unless the patient is treated with IV cyclophosphamide, is now treated with mycophenolate or other pills, that drug adherence may be a concern, and then maybe tablet counts are needed and no biopsy, and a social intervention may be needed at not changing the drug. There could be a genetic drug resistance, for which we have pharmacogenetics, and there's quite a good literature about this in the drugs that we use for lupus nephritis, and here changing the therapy would be the right choice. And there could be also other kidney diseases that may be behind that problem, and you see already here that there's now some literature in the black people, Afro-American people in the US, that this APOL1 genetic variant is a risk factor for CKD, and this is also shown in patients with lupus, that those people that have those risk variants rapidly progress to end-stage kidney disease, and this has now even been called a lupus podocytopathy, so some disease entity that may be similar to the primary FSGS entities. Well, our patient was an African. She was from Senegal, and that's why we considered this option and went for extended next-generation sequencing and looked for APOL1. She was an unlucky one. She had both the risk alleles, each of them inherited from the mom and the dad, that we also sequenced. And in addition to that, she had a heterozygous, a homozygous mutation for nephrin, although she had not presented as a nephrotic syndrome of the Finnish type at early age, so she has an adult onset. So in the end, this was a patient with 3 diseases. She had the lupus nephritis, obviously. She had the primary FSGS, and she had also the APOL1 risk allele, and maybe that's the reason why she progressed so fast to end-stage kidney disease. So as you can see here, going by guidelines with this patient, you end up on dialysis like we did, but maybe initiating such diagnostic steps a bit earlier could help other patients in the future. Well, there had been a fascinating paper published last year in Cell, first lupus paper I've seen in Cell, I have to say, trying to address an approach to personalize immunomonitoring in lupus patients. It's a study that looked at a big cohort of pediatric patients with lupus nephritis, and they had divided them in a training set and in a test set, and they did transcriptomics, so mRNA profiling on the blood cells of these patients that were donating blood at several incidents. And the attempt was to group the transcripts to modules of genes with a similar pro-inflammatory or wound healing properties, so there's a way of grouping them. And it was quite interesting to see that there were this, what we call the interferon signature. You know that interferon alpha signaling is a very important component in the pathogenesis of lupus nephritis, was obvious in the majority of patients. Then the plasmablast signature, these are the precursors for the plasma cells that produce the autoantibodies in lupus, and these precursors are circulating in the blood and are also good biomarker of disease activity, were present. And also the neutrophils are now recognized as important in the pathogenesis of lupus nephritis, because these neutrophils undergo net formation, they explode, basically put their inside out, and provide a lot of nuclear antigens to drive adaptive immune responses that are important in lupus nephritis. And one that these people did, that for the several time points the blood was analyzed, they developed certain courses how that could go up and down, and to generate prediction models to then in the future with a single blood sample then to predict what will happen in the future. Obviously this is something that is currently done only in very few centers in the world, but I like to summarize that lupus nephritis clinical trials suffer from insufficient endpoints, and proteinuria that we use currently should be replaced maybe by rebiopsies, especially in randomized controlled trials, and this is now what people try to do. And immunomonitoring, like I showed you, will involve other technologies like genetics and these RNA profiling, but this can only be done in specialized centers, and this is something that we advocate, that people with the rare diseases, including lupus nephritis, should not be treated by everyone, everywhere, but should be taken care of in specialized centers that have also these diagnostic tools available. Thank you.
Yes, we have time for one or two short questions.
There on the right.
Yes, down number 3.
Good day. I'd like to ask, for the patients that you've done protocol biopsy for and have found that there is ongoing histological activity, how would you go about treating them? Do you get a full course of immunosuppressants, or do you attenuate the treatment, since clinically they look pretty quiet? And I mean, after that, how do you monitor? Do you actually...
Sorry, I didn't understand the first part.
I do apologize. Okay, so for the patients who have received a protocol biopsy and has shown histological activity in absence of a clinical activity in terms of proteinuria, for example, how would you go about treating them? Do you actually give a full course of immunosuppressive therapy, or is there an moderated therapy that you do, and how would you monitor? Would that be with a subsequent biopsy again?
Well, what we do is that we start with the induction therapy, and we consider rebiopsy in those patients that do not have a full remission with proteinuria at around 10 to 12 months. And then I recommend a rebiopsy, because I simply don't know whether the patient needs more immunosuppressive therapy or needs more ACE inhibitors and no immunosuppressive therapy. So we do not go by the usual induction and maintenance thing without knowing whether the patient needs it or not. And this I cannot decide based on proteinuria. I need to know if there are still immune complexes in the kidney or not.
Thank you.
Okay, because of constraint of time, just one more question from mic number 1.
Okay, thank you. Hi, Hans. Paolo Schena. I would like to ask you if you think that whole exome sequencing may contribute in personalizing therapy, mainly when you have familial lupus nephritis too. What is your opinion about whole exome sequencing?
I mean, there are many ways how genetic abnormalities can change or affect lupus nephritis. The familial cases are very few. I mean, I have some mothers and daughters in my clinic, but it's very rare. And some of them have complement deficiencies, as it's well described. But I think abnormalities like APOL1 or UMOD mutations or other variants that contribute to CKD per se and not necessarily to lupus have also an important role in modifying disease progression. And here we are just starting and have not yet established in the clinic genetic testing for these aspects.
Well, thank you very much, Hans-Joachim. And now I would like to present my